Hi everyone, I'm going to finish up my ENT lecture. So I am going to go back to tonsils and adenoids. I went over all of the pathology and anatomy. I want to go over the actual procedure with you. So on this one, I'm on page 674. So page 674, it goes through the main parts of the procedure. I won't go through every step because every surgeon's going to do it a little bit differently. So instead, I'm going to hit a couple things. So look at your preoperative preparation. Your drape is always going to be the same. So on your draping, that's called a head drape. So it's just like what I described in ENT surgery, a half sheet or two of them, as it says in your book, with a towel. You wrap it around the head to pull the hair back, and you put a towel clip to secure it. So again, every surgeon's going to do it different, but the beginning is pretty much the same. So look at step one. We're going to put in a self-retaining retractor, usually a mouth gag. This one, of course, connects to your Mayo, so you have to be very careful if you're using that one to not touch that Mayo during the case. Otherwise, it's going to be surgeon preference, so you just need to know what the surgeon wants and read that preference card. Okay, looking at step one, I want you to at least know what these Red Robinson catheters can be used for. So they can actually put it in the nose and then come out the mouth and use it as a uvula retractor, because the uvula is going to get in the way a little bit. So they can retract that out of the way with that Red Robinson catheter. After that, they really grasp onto the tonsil. They can do that with that White Alice clamp, with a forceps, whatever they're choosing, and then ligate it off. So they could use this suction bovie, as you see here. They could use a regular bovie with an extender tip, as you see here. They could use a special device that cuts and coagulates at the same time. So there's lots of different options for this. What I want you to know is there can be severe bleeding afterward on tonsils and adenoids, so you have to be careful with that, especially in adults. So the end is going to be very different, but you want to really inspect for hemostasis on this one. So lots of different options for how to actually cut it off. Remember, you got that 12 blade that's angled. You have the sickle knife. You have, as I said, this bovie, section bovie. So many different ways to approach this one to actually do the resection. But make sure you have specimen cups available and you separate those tonsils and the adenoids. And again, this is a non-sterile procedure for this one. So tonsil and adenoids, simple, quick case. You can get a lot of cases that day if you have tonsils and adenoids. A longer case, a parotidectomy. So this one is very cool. I like parotids. It's because it's a little dangerous. You're right on that cranial nerve 7 the whole time. So you have to carefully dissect around it. You'll see it the whole time. You can use neuromonitoring. So it's actually a probe that you hold and you can get that nerve to stimulate, so you can check and make sure you're not damaging the nerve throughout the case. So very cool, parotidectomy. I want you to read through this anatomy really well. So on the anatomy, look at the excretory duct called that Stevenson's duct. I want you to know where that's at in relation to your parotid gland. And again, they're going to be dissecting down that facial nerve throughout this case. So look at your 1, 2, 3, 4, 5th bullet point. Your parotidectomy is the excision of a portion of the parotid gland. So common disorder is the formation of stones in that Steno's duct. So that's sometimes why we are in here doing a parotidectomy. Surgery is performed to clear the ducts or too many stones are present to remove the gland. So a very interesting incision right in front of the ear on the side of the face. You will always put a drain on these because there's so much blood and ooziness after the case. So with this one, I won't go through it step by step. I want you to see that it's really small, fine dissection with mosquitoes, small hemostats. And we're elevating skin out of the way. We're using little skin hooks, tiny, small instruments, and as I said, neuromonitoring. So very precise procedure. Parotidectomy is always going to end with a drain. Okay, UPPP. So uvulopalato-pharyngoplasty. So you've got the uvula, the palate, the pharynx, and plasty, we're revising it, we're fixing it. So done to correct sleep apnea is the main part I want you to see. So we're going to remove that uvula and part of that soft palate. So this is a good visual for you. So the roof of the mouth is two sections of the palate. So make sure you understand which portion is the hard palate and which portion is the soft palate. So review your anatomy and just really know that the UPP is performed for patients with sleep apnea. And you can see exactly where they're making the incision on this one. I will tell you, if you look at 679, that they typically use that 12 blade to do this one. So another rare time you get to see the 12 blade. If you flip it over to 680, you can see more images of how that one is done. But again, I want you to know this one is done to correct sleep apnea. Okay, much cooler case, total laryngectomy. So of course, this is for cancer usually of the larynx. So because we have a tumor that's so involved it gets into the larynx, we have to do a laryngectomy. That means we're taking the patient's voice box. So if the patient wants it, we can put in a voice prosthesis so that they are able to talk. It won't sound the same. They might have to use an extra device to hold up to their throat to allow their vocals to be heard, but that's better than not being able to talk, right? So I think it's amazing that we have options for these patients. So laryngectomy, it immediately goes over the anatomy. So I included a picture so you remember where your vocal cords are and you see the section we're really focusing on. So remember, on the larynx, know where the larynx and the pharynx is, separate them. I want you to know there's 9 laryngeal cartilages and the hyoid bone. That's that rigid framework, basically. So there's muscles and ligaments all around it. Remember that hyoid bone is that cool floating bone. What's cool with some of these cases is you'll get to see them cut the hyoid bone. First time I saw that, I thought it was amazing because it's such a small, thin bone and it's floating in the neck that they actually can cut it with curved Mayo scissors. So very cool to see, but of course, this is a terrible day for this patient. So what's cool is the reconstruction. We can make it better. So again, go over your cartilage, your laryngeal cartilage. Understand how your epiglottis works to help save you from choking. It's like a little flap that falls down to prevent you from, you know, sending something down the wrong pipe, as people say. So preventing you from choking. So the epiglottis, if you don't remember, is that elastic cartilage. I also want you to pay attention to the thyroid cartilage. So this one looks like a shield almost, and you can see a good picture of those on the next page, 682. Okay, the next portion I want you to look at. So I just said your thyroid cartilage, right? So right after that, it talks about what's commonly known as the Adam's apple. So I want you to know which cartilage that is, and that's your thyroid cartilage. Okay, so if you remember your cartilages, your epiglottis, your different parts of the throat, the larynx and the pharynx, then you should be okay on that section. And if you need a better picture, more involved inside the throat, page 682, your next page. So I included this picture so you really understand the difference. So larynx, voice box, pharynx, you can see all the different sections of the pharynx. So that tube before the esophagus. So pharynx turns into esophagus. So nasopharynx, oropharynx, laryngopharynx is right matched up with that larynx over here, your voice box, and then the esophagus. So really know this anatomy. Okay, so if you don't remember how the epiglottis works, this is also a great page to show you that awesome protective part of our body that prevents us from choking on our food. Another cool thing to see on page 683, the vocal cords. So we actually do some throat surgeries where the patient might be awake, believe it or not, and because of that, you can hear them. So we can put a scope in and have them talk. So you can hear them talk and see their vocal cords move to make the sound. It's very cool. If you are bored, you can Google a YouTube video of Steven Tyler from Aerosmith singing while they have a scope down his throat, so you can see his vocal cords dancing as he hits a high note. So you can really understand the vocal cords if you find that video on YouTube. So flip over page 684. So it goes through this laryngectomy step by step. I'm going to tell you some big things about it. So this is a big neck dissection. So looking at number 1, laryngectomy with neck dissection. We've got a big tumor. We're dissecting all kinds of stuff to get to that larynx. So long entry points. Takes a long time to get to it. What I want you to realize is 2 things. I told you about the hyoid bone, that they might have to cut that and dissect it. That's number 8 on that page. Look at number 9 on page 685. I want you to also know that we're going to have to do a trach now because of this, and that's in the middle of the case. So instead of making an incision in the skin, opening it, and then making an incision in the trachea, we're there. We're looking at the trachea. We did a neck dissection. We're right there. So we're just going to put a tube directly in there as we get to the point of cutting that hyoid bone, really. So read through your dissection. It's really cool. You get to see the carotid, all different types of anatomy, anatomical features is what I should say. But after they cut that hyoid bone, they're really in the neck. You can see the trachea. So now we can perform the tracheostomy. So we perform the tracheotomy and we place the tracheostomy tube. So now it's considered a tracheostomy. And then we are going to incise the larynx. So at that point, we can safely take out the larynx and the patient is still going to have an airway throughout the surgery. Because think about it, if we just take the larynx out, we are going to hurt their airway, right? Because they have an ET tube in. They're under general anesthesia. The machine is breathing for them right now. So airway is a big thing on this one. You have to communicate with anesthesia. And think about it, you're going in the airway. Is the airway sterile? No, but we're in the neck, and that is sterile. So it's very difficult. You have to be very vigilant because remember, you're working with ENT surgeons. They're not worried about sterility. You are. You are preventing infections for your patient. So it's not like you're commanding the surgeon if you're wondering that as you're going through this, especially on these dirty cases. You're not telling the surgeon what to do. That's not your place. A simple reminder, they're going to say yes to that. They don't want their patient to get an infection either. What you can do to make sure they do it is be ready. So like I always had an extra pair of gloves on cases like this for my surgeon. So if we change that ET tube out, as soon as we put it in, we went in that airway that's dirty, I'm going to say, okay, I got a new pair of gloves for you. I have them in my hand ready to go. Then they're not going to argue with me whatsoever. Okay. They pop their top glove off, they get a new glove for me, and we're good to go. Now, if I said, hey, stop, I think we need to change your gloves, and I didn't have the gloves ready, they're going to keep moving. They're not worried about infection. They are worried about getting this larynx out and keeping the airway open. So they are worried about patient safety too. We just have different priorities. So stick to your priorities, sterility and preventing infection. Okay, so for this one, again, they're going to have a trach. That's what I want you to get from laryngectomy. We're going to get a trach in addition to a laryngectomy. Okay, so because you do a big neck dissection to get the laryngectomy, I want you to see an even more involved neck dissection. So this means their tumor was more involved. When we did radical neck dissections, it was usually a laryngectomy with other pieces of tumor taken out depending on where the tumor progressed. If it progressed into the bone, it was into the mandible. So if we did a radical neck dissection, we might have to also get into the mandible and cut the pieces of tumor out. So very involved case. This is something where you're going to have lots of things working together. So look at page 686. Radical neck dissection with mandibulectomy. So if you're doing a mandibulectomy, you're taking out the mandible, right? Let's look at that. Mandibulectomy. Part of their mandible is gone. Yes, we can put a plate there to cover it, but that's not going to allow them to live their life normally, talk normally, eventually eat at some point. So because of that, we are going to do a fibula free flap with it. So I want you to go ahead and on this procedure, 17-16, I'm on page 686. Radical neck dissection with mandibulectomy, and now you're going to add with fibula free flap. And it says it in your book. I just like you to add it to the title so you know what we're talking about here. So that means we can do free flaps from other places. So I involved this picture for a reason. Sometimes when it's just a hole in the neck after we took the tumor out, we just need soft tissue and muscle. So you can take a pectoralis major flap and they flap it up right into the neck. It's nice and close. We can keep that vascularity. You don't need a microscope to anastomose two vessels. You just flap it up. So it's called a rotational flap. What I am going to talk about is a free flap from a fibula. So they take pieces of the fibula bone and they mold it into your new mandible. It's actually the coolest case I've ever done. That was my first love. So I started in ENT, and it wasn't the little, I had almost never, except for school, done a tonsil and adenoids or ear tubes. This is what I did, free flaps. So there's surgeons that can specialize, as I said, more involved. So these were ENT surgeons that specialized in microvascular surgery. So that means they could do these rotational flaps, or they could do a free flap from another portion of the body. That means you've got several setups and several teams. So looking at page 686, see how it says team A, team B. As you're going through this one, because it's difficult, understand they want two teams for sterility. We're working in the mouth and we're working on cancer. Both of those things are considered dirty. If we take a free flap from the leg, a free flap or a rotational flap from the chest, either of those are sterile. We need to not cross-contaminate and make those areas dirty. So that's why it says team A and team B. I never had that luxury. I was team A and team B. So we would do the cancer dissection, change out, new gown and gloves, get our graft from the fibula, sew up the leg so it's all clean, then put it in the neck, bring over the microscope, do our anastomosis. So that's for the tissue and the vessels, and then we're taking that piece of fibula and we're molding it just like this picture into their new mandible. So this could be 12 hours plus. So when they first started it, it was a little bit longer than that, and they got better and better and better at it, and I was able to eventually complete a full free flap. As I said, the whole case, radical neck dissection, mandibulectomy, and a free flap within my 12-hour shift. So it was cool to finally see it from beginning to end, but very involved case. You'll be tired after this one. This is a type of case you might see at Cancer Treatment Center. Okay, so let me go back on this one because there's just so much to it. So again, radical neck dissection. So right now we are still sterile. We're not in the airway or anything like that. As soon as you switch from the neck to the mouth, dirty, right? So if the mandible is involved, it's going to get dirty. This also goes with the tongue. So look at surgical anatomy and pathology, all these bullet points. Middle section, last bullet point, it says a glossectomy may be an additional procedure. So if their tumor is involved in their tongue, you actually have to remove part of the tongue. And we can do a flap for that. So you can get a piece of muscle and connect it to the tongue. Now there's no taste buds, you're not gonna be able to taste your food, but you'll be able to eventually talk with some speech therapy. It's pretty amazing what we can do. So read through this one, understand why there's a team A and team B. I don't expect you to fully understand this case. There's a lot of different things going on. So I want you to understand the difference between free flap and rotational flap. When it's a free flap, it's from a different part of the body. That means there's no vascular connection. If it's a rotational flap, there's still blood flow connected. We don't need a microscope or any of that stuff. So hopefully you can separate the two a little bit better. Let's look at page 688. So it starts going through the procedure. I want you to understand that number 4, there's always going to be a neck dissection. Number 6, it's going to be careful, tedious dissection around nerves. Number 7, that they're going to go around that sternocleidomastoid muscle. That's my favorite neck muscle because it goes diagonal across and it allows you to turn your head right and left. And usually I had my hands on a Richardson retractor retracting that muscle during that point. So sternocleidomastoid muscle. Number 8, I want you to know you get to see the internal jugular vein. It's awesome. You need to have 2 big clamps ready for that one. So internal jugular vein and of course silk to deal with ligating these vessels. Number 9, know that this could involve cervical lymph nodes because it's cancer, right? So it goes down those lymph nodes and that's how it spreads. So Very common to take lymph nodes with it. You're gonna want so many specimen cups for this procedure to be prepared. Number 10, they jump to the mouth, mandibulectomy. What my surgeons did is we covered up the neck with another drape. Every facility is different. As long as you are not contaminating that open neck where it's sterile, then you're okay. And then going to the next page, number 11 is retracting. Number 12, we're working more on the mandible. Let's look at number 13. I want you to know the terms. So fibular composite graft. So yes, so we took a piece of the fibula bone and we're cutting it into pieces, but I want you to know it as we harvested the fibular composite graft, because we're going to cut it into pieces. It's going to be a composite graft at the end. Okay, after that, reading, again, you got to read through every step. I'm skipping a lot. Number 18. So because we're taking a piece of the fibula bone, you're going to need a saw. So you get to set up the sagittal saw. Another reason I liked it, I felt like I was doing ENT, vascular, plastics, and ortho all in one case. They will close up the leg. Then number 21, under the microscope. So now you know it's a free flap or anastomosing vessels. Otherwise, we wouldn't do it under the microscope. Okay, after that, they're going to move that graft up, make it that pretty composite graft, and then at the end of the case, when they're done closing, 12 hours later, we're going to put a Jackson Pratt drain in. I've also seen surgeons use hemovac drains for this because there's so much oozing after this long, bloody case. So it can be a little more involved. So for this one, I'm actually going to post a story about a patient that shared his story, and actually they made a commercial about it in Oklahoma City. So he had a firework accident. We normally do these cases for cancer, but he actually had a firework accident where his face was right over it. And so when the firework went off, it blew off a big chunk of his mandible, lots of facial fractures, his orbital bone was gone, and his eye was gone. Because of this, he takes lots of time to coach people on firework safety and things like that. And he advertised his surgery in much detail and talks about it openly to push firework safety to prevent this from happening again. So just wanted to throw that in there so you know it's not only for cancer cases. There are some traumatic instances where we have to do this case for reconstruction. Okay, so one last thing, your pearl of wisdom on 691, separate setups. Separate setups for dirty things in the mouth, separate setups for cancer. Make sure you know that by heart. All right, so I put a little note in there for you, repeat of what I just said. Anything in the neck is sterile, anything in the mouth, dirty. And our last case, so TMJ surgery. So this is related to grinding your teeth. So if you're that person that grinds your teeth like I do, then you might have bruxism. So that is grinding your teeth and you might have to get TMJ surgery. So it does bother me a little bit when people say I have TMJ. That's incorrect. That is the joint. So temporomandibular joint. To fix it, we're going to do an arthroscopy like we do in ortho. So this is a bone, we're doing arthroscopy, it's just ENT because it's the jaw. So know that mandible is the longest, strongest facial bone. Know that that TMJ contains that condylar process, so you need to look at that anatomy. And then the arthroscopy, so you can see where they're actually at. On 693, that's where they're going to be working at. Look at that picture right there. So this is minimally invasive. We're going to make a stab incision and stick a scope in and work through the scope. So that is my last one until I get to the most important case in ENT. So it's kind of separate for me. So this is related to bruxism, grinding the teeth. Again, it's arthroscopy of the jaw. Okay, tracheostomy. Tracheotomy until you put the tube in to separate it for you, and then it's a tracheostomy. So the tracheotomy, this one is performed for many different reasons, but I want you to know it for emergencies. Airway emergency, we got to get in there quickly. So to me, this is just as important as any other emergent case. So some people might say, You got to know how to do open belly trauma. You know, a heart tech might say you got to know how to do a chest trauma when it comes in. L&D, they're going to say you got to know what to do for a C-section. For every single one of those cases, they could have an airway emergency. If your patient isn't breathing, doesn't matter how much they're bleeding inside, does it? They have to make sure we have an airway. So for me, the trach is the biggest, most important case. So understand your anatomy. More importantly, understand the instruments to pass in the right order. So tracheotomy, it goes through your anatomy very well right here. So understand your hyaline cartilage, the C-shaped rings. Understand where we're going to put this cric hook. So this cric hook is going to go on that cricoid cartilage. So it says in your book, News tracheotomy hook. That is correct. I've also heard it called a cric hook because we're putting it on that cricoid cartilage. I want you to look at practical considerations on 695. So tracheotomies have been performed in the field, emergency department, ICU. I've heard of it being done on an elevator. So if a patient's airway is not open and we can open it, that's going to happen really fast and you need to be ready for it. This is a good example of something that they're not going to worry about sterility as much. So if this is an emergency, you might see somebody grab a bottle of betadine and just splash it on the patient's neck and then ask you for a knife. They might skip that altogether and just get in that airway, deal with the infection later. Because again, you can't do anything if your patient isn't breathing properly. So let's look at the order. Page 696. So under your procedural considerations, number 5. Because at the beginning, we're making an incision in skin, we're not to the dangerous part. We're retracting some muscles with some Army Navies. We move the thyroid isthmus muscle out of that way. Here's the part you need to know. Number 5. Tracheal hook is placed on the tracheal ring, and the incision is made into the second tracheal ring. So, hand trach hook, hand 15 blade. Right after that, spreader. When I say right after that, I mean have it ready in order and on your Mayo, and it should be in their hand. I would go trach hook, knife, spreader. They shouldn't have to ask for it. They should never have to look away. Patient airway. They have to secure it very quickly. They might struggle. That always puts you in a little bit of a panic. Like if they're struggling, they've made that incision in the airway, they're struggling to get that tube in. All you can do is hand them what they need quickly and be alert and 100% invested in this case so that you can help if something goes wrong with their airway. One more time, tracheal hook, knife, tracheal spreader, and then the trach. So the tracheotomy tube, I'm going to actually show you guys this part in person, but when you hand that tracheotomy tube, it's got a little obturator in place. So it's got the obturator in the center. So you're going to put it in, they take that obturator out, and they're going to put an inner cannula in to where they can hook up to it. So that little inner cannula that you first put in there, we want that piece. We want to send that with the patient to ICU. So I would always wash it off in the saline and put it in a nice clean spot so I can give it to my circulator to send with the patient. So again, that's number 6, putting in that inner cannula, and that's allowing an opening so we can get the secretions out, and of course so that we can hook it up so the patient can breathe. So after that, the endotracheal balloon is inflated. That's by anesthesia. The tracheotomy tube is secured. The wound is closed. So it goes over it really quickly, but really you go through these steps. You get the trach tube in. As soon as the balloon is inflated, I always kept the syringe connected to it, so you don't have to hand the syringe, it's just there. They push the air in, the balloon inflates. Everybody looks at the O2 stats and we wait. That's what your book left out. We wait to make sure the airway is really secure. They're constantly talking to anesthesia. Everybody's watching the monitor to make sure the patient is breathing right. It can happen that you go in and it's not really in the trachea. So they blow up the balloon, they're like, we're not getting any oxygen. Let's try it again. You have minutes, right? Every second you're taking oxygen away from your patient's brain. So your surgeon might make a mistake. So the least you can do is be 110% prepared for this case, airway emergency. So for me, this is the case. This is the reason why I do not take my blade off of my knife handle until I absolutely have to. So what you'll see very commonly, end of a case, they're going to be rushing you to clean up. All right, let's clean up. Let's get this room turned over. If we just worked on the neck, or if for any reason I'm worried about their airway, I will delay the cleaning. I will keep that knife blade loaded. That's for my patient's safety, because that's happened to me. We've done a normal case that had nothing to do with the throat. I turn around, anesthesia is having an emergency. My surgeon says, we're going to trach right now. I had to load the knife handle on the knife blade, probably like this, and it took seconds away. Don't take seconds away from your patient. Leave the knife on the knife handle. You never know when you're going to have an airway emergency. So example, thyroidectomy, we're working on the neck. For those, it is common knowledge, it's understood that the scrub tech is going to keep their sterile field sterile even though the case is over, and they're going to leave a knife blade loaded. So if we have an airway emergency, we can trach them. So you're always ready to go. So good thing to find when you start externship is, where's the trach tray? For me, that goes number 2 right behind the crash cart. So lots of people know to look for the crash cart, look for fire extinguishers, things like that. I'm looking, where's the trach tray kept too? Because I want to be able to secure my patient's airway or help them secure the airway. Okay, so that's your trach hook and spreader. This is a great visual to how they're actually going to do it. I want to point out one other thing. The syringe. The syringe is vital. I've been not scrubbed in, watching a trach happen. They put the tube in and they can't inflate the balloon. If you can't inflate the balloon, we don't have an airway. So make sure you have that syringe attached and you're ready to inflate that balloon too. I really feel like that's the only thing they didn't focus on properly on this page. So on page 696, I want you to really spend some time. This is a good case to memorize. I think I told you guys that on a lap chole and on a lap appy, and definitely a C-section. So 2 extremely common cases. C-sections can be emergencies, and now tracheotomy, definitely airway emergency. So I think it's cool to be a part of being able to get somebody's airway back. That sigh of relief when the O2 stats are good, the patient's okay. We can secure the trach tube now because our patient's going to be okay. They have the airway. So you have a big responsibility. I hope you take it seriously and you study, especially this case, but the rest of ENT surgery also. If you have any questions about ENT surgery, please send me a message or send me an email. I'd be happy to discuss some different parts of this chapter because it's really involved. So thank you guys. If you have any questions, send them on over. And I'll talk to you soon.